to talk about some of the coding concepts for procedures on the integumentary system. So you will want to have your CPT book in front of you so that you can follow along with some of the codes that I want to point out. I'm not going to go through every code that you're going to need for this section, but there are just some things that tend to be a little particular to the integumentary system, and I would like to point them out to you before they have an opportunity to trip you up. Okay, so the first code I want you to go in your book to is code 11200. And if you need to pause your video so that you get your book to that page, please do so, and then restart the video when you get there. But with your code 11200, which is removal of skin tags, notice a lot of your things in the integumentary system are quantity based. So that code is up to and including 15 lesions. You can see in the picture here, this patient has a whole bunch of skin tags. So if you remove up to and including 15, you simply code 11200, and that gets you paid for all of them. So if you do more than 15, each additional 10 lesions, you're going to add a 11201. And notice it says, or part thereof. So even if you do one beyond the 15, so let's say you did 16 lesions and your code 11200 only got you paid for 15 of them, you still have one that isn't paid. You can still add on those additional 10 lesions because it says or part thereof. So even if you only did one of those additional 10, you can add that code. And so if that was your answer, you would write it like this. Oops. But you would, of course, type it correctly. But what if we did 30 lesions? 30 skin tags. How would we bill that? Well, no different. You still code the 11200 for the first 15. Then we're going to add on a 11201 to get you paid for the additional 10. But now I'm only paid for 25. I still have 5 more that I haven't been paid for. So I need to add on another 10. We're going to type times 2. So we're going to add those additional 10 2 times. And that would be the correct way to code that one. These are not specific to body part. So anywhere on the body those skin tags are, we can add them together and code them like this. All right, the next one I want to talk about is shaving of epidermal lesions, which is the very next grouping of codes. And a shaving is just like you're shaving your legs or shaving your face if you're a guy. You take a blade, run it against the skin, and anything that's over the skin, just like a blade of hair, gets shaved off. So this could be a mole. This could be any other kind of lesion that is raised. Obviously, we would do this with some anesthesia because that would hurt. Okay. So when we bill this, it includes the anesthesia and if we have to cauterize the wound afterwards. So let's say we took a mole off, it might bleed a lot, so we might have to cauterize it. This is a wound that does not need a stitch to close it up. Okay. It just needs some pressure and a bandage, and it'll heal on its own. So with this grouping of codes, they are separated here on the size. What was the size of the lesion that we removed from the patient? Under a half a centimeter, half to 1 centimeter, 1.1 to 2. How big was it? Is how they categorize it. It's also categorized by where on the body it was. This is for a single lesion, trunk, arms, or legs. Oh, it wasn't there? It was somewhere else? Okay, the next grouping is for your scalp, neck, hands, feet, or genitalia. Oh, that's still not where it was? Okay. The next code down is the face, ears, eyelids, nose, lip, and mucous membranes. That has now covered the whole body. That's the end of it. So you would need to locate your body part and then go with the size of it. Now notice that those codes all say single lesion. So if I removed 3 lesions from the patient, I would need to code all 3 as separate codes. Now, if you find that 2 of them end up to be the same code, so let's say we did 2 different lesions, both of them on the face, and both of them were under the 5 centimeter mark, I would have 2 of them coded as a 11310. So I would do the times 2. What order would you put those 3 in? If you had 3 lesions, you'd want to go from the biggest lesion to the smallest lesion. So these 2 were both 0.5 centimeters or less, but let's say one of them here was the 2 centimeter size. I'd want to list that 2 centimeter size first. Okay, scroll down just a little bit to code 11400. And this section is on excision of a benign lesion. So the last ones we were doing was a shaving. So just sliced right across the skin and removed it. This one is not shaving, and it actually tells you over here for a shave removal, go see those codes we were just looking at. So it actually tells you if you did shaving, you're in the wrong spot. The skin section will require you to do a little more reading than you may be used to. We've always talked about how these guidelines are the directions for the section. But in a lot of sections in CPT, you haven't had to read those paragraphs of guidelines to be able to figure out what you need. But in skin, you may find that you're going to do a lot more reading of those guidelines because the section sometimes will mix in your brain. For example, when we get to stitches, which we haven't gotten to yet, I always forget how the rules of stitches work. So every time I would get to that section, I'd have to reread it and relearn it and then make my code selection. Okay. So you may find that you're doing a lot more reading. Okay, so this is an excision of a benign lesion. Benign lesion means not cancer. So if you are dealing with a cancerous lesion, you're in the wrong spot, but it's the very next spot. We're going to look at it next. This includes anesthesia, and it works a lot like the shaving we were just looking at. It's separated by body part, and then it's separated by size, just like the shaving was that we just looked at. We're going to talk about destruction here in a minute, but it does tell you there, if you did a destruction instead of an excision, you're in the wrong place. But we're going to talk about destruction later. The other thing with excision of lesions, whether it's a benign or a cancerous lesion, when we take, let's say I have a suspicious thing here on my hand and we take it off, until we get it back from pathology, how do you know if it's cancer or not cancer? You don't. So if I worked for the dermatology doctor and the doctor just took this lesion off a patient's hand, we have to wait for the pathology report to come back before we can code it. So these types of removals, the coder is actually going to be working several days behind because they have to wait for that pathology report. We can't guess. I think. It looks like. It's probably. None of those things work. You have to have a pathology report that tells you for sure that it was a benign or a cancerous lesion. Okay. The next thing with a lesion removal, the lesion may be large and it may be deep. Meaning that when the doctor removed that from my hand, he might have had to do some really significant stitches to close me up. Repair, which is the stitches, an intermediate or complex closure should be reported separately. We haven't gotten to stitches yet. Stitches have 3 levels of complexity: simple, intermediate, or complex. So it tells us here that if it was intermediate or complex closure, we get to bill for it. But if it was a simple closure, it's included. It goes on to say, for excisions requiring more than a simple closure, here's your codes. Okay. We're going to look at those in a minute, and you'll understand the difference between simple, intermediate, or complex before we get done here. But notice, if you did that repair, let's say this required an intermediate closure, and you don't bill it because you're allowed to, and you don't, you just lost your doctor some money. So knowing the rules help you code correctly. So we've got the benign lesions, followed by the malignant lesions. Your closures work the same way. Notice it's all separated by body part and then size of the lesion. I scroll down just a little bit. So if you want to come down here to code 11983, and I'm right underneath it. It's the repair and closures here that I want to talk about. And this is exactly what I was just referring to a minute ago, that we have simple, intermediate, and complex terms. They will not say simple, intermediate, or complex. They will use other words to describe the closure, and you have to equate what the doctor said into these terms, okay? First of all, let's talk about what a closure is. A closure is any wound closure using sutures, staples, or tissue adhesive, either singly or in combination with each other, or in combination with an adhesive strip. However, if you use adhesive strip as the sole repair material, you don't get to call that a wound closure. So if they just put like a butterfly Band-Aid on it and say it'll be fine, that is not a closure, that's a Band-Aid. Okay? But if you use the adhesive strips in combination with these other things, so sutures are stitches. Staples are exactly that. A tissue adhesive is a wound glue. It's like crazy glue for the skin. My son got a cut under his eye. We went to the emergency room, and the doctor actually closed it with glue. There was no stitches involved, no needle, no nothing. He actually was able to get the skin lined up and glue it. And that was fine. It healed. Still is a scar, just like stitches, but it's a nice straight scar. My son went to the same emergency room another time, and he had one here on his chin. They actually put stitches in on the chin, and the difference, and I asked, I said, hey, when you did this one, you did the glue. This one, you're doing stitches. What's the difference? And he told me, because on the mouth, you move it all the time. You eat, you talk. There's no way this is going to hold still for glue. You'll rip it right open. But because under the eye is still, it was perfect for the glue. Okay, so that's what the tissue adhesive is. Okay, so there's different ways that we can close the patient's wound. When somebody needs stitches, there are different complexities. So the simple repair, and you may want to highlight these in your actual code book, or at least the simple, intermediate, complex, maybe just those words, maybe not the whole paragraph, because that's a lot of highlighting. A simple repair is for a superficial wound, primarily the dermis or epidermis, without significant involvement of the deeper structures. It's a surface cut. An intermediate repair is the same as above. However, it may need layered closure. You may have heard somebody say where they had to have stitches on the inside and stitches on the outside. That's a layered closure where we had to close different layers of the skin with different layers of stitches. And it also could mean that it was a single layer closure, which is normally a simple, but it may have required, it was heavily contaminated and it had to have extensive cleaning and removal of particulate matter, which would bump it up to the intermediate level. So if this is a kitchen wound, like a knife, I was cooking and I cut myself, that probably doesn't have a lot of junk in my wound. Maybe some saline wash and we're good. But let's say that the cut is because my hand went through a glass window. Maybe I've got a lot of glass in the cut. Or road rash, if it's like I fell off my bicycle or my motorcycle or something. There's a lot of dirt and rocks and junk in the wound. And maybe if they wash it out, it doesn't clean out. And they actually have to sit with tweezers and start picking out all the pieces of the glass from the wound. That is something that would be considered heavily contaminated and would take that simple layer and be able to bump it up to an intermediate level for payment. Okay, complex is even higher than that. This one might have exposure of bone, cartilage, the tendons. It might have, might need that debridement again. You might need retention stents put in, like drainage tubes coming out of the wound after we stitch you up, okay? So now it's getting even more extensive than what I had described previously. So the first step in coding is we have to determine, is this a simple, intermediate, or complex repair? Okay? Just like the other sections we've already looked at, they're separated by body parts and then separated by size. And by size here, we're talking how much stitches were put in. So when the stitches are put into the arm, we're going to measure it. It was 2 centimeters, 10 centimeters, etc. All right. It's a little more complex than that. So there's this piece of direction here that I skipped. Number 1, the repaired wounds need to be measured in centimeters. If your doctor is documenting in inches, educate him. However, 1 inch equals 2.54 centimeters. So if your doctor is documenting in inches, you have to do the math conversion. So it's not a bad idea in your code book, right, where this section is that you write this math formula, 1 inch equals 2.54 centimeters. I don't have it written in my book anymore because now I know it by heart, but I had it written in my book for many, many years because I didn't know it by heart. That's number 1. Number 2, when multiple wounds are repaired, add together the lengths from those in the same classification and from the anatomical sites that are grouped together to the same code descriptor. What? Okay. So let's say our patient, I always make it really extreme, got stabbed a bunch of times all over their body. Okay. So we've got multiple stab wounds to the chest. We've got one to the arm. We've got one to the leg. Okay. We got one to the face. Okay. Maybe it wasn't a stab wound. Maybe that one was just a slice that needs stitches. Okay. So this patient has multiple places on their body where they need stitches. So what they're saying is some of these are going to get added together. So it's not like the lesion where you had to code every lesion separately. You're not going to code every stitch separately. So if you give me 2 inches or 2 centimeters here and a 1 centimeter here and a 2 centimeter here and a 1 centimeter here, we're going to do some adding together. But there are rules on how we add it together. First of all, to add it together, they have to be of the same complexity. So if this patient has centimeter on the left cheek and a 1 centimeter on the right cheek, are they of the same complexity? The answer is yes, we can add them together. The answer is no, we cannot add them together. So let's say when we look at the doctor's documentation, this one is simple and this one is intermediate. It's deeper. We cannot add them together, even though they're the same body part. They're not the same complexity. Those would need 2 separate codes. So, same patient also has a 1 centimeter on the chest. And in looking at the doctor's documentation, it's pretty superficial. It was also a simple. So you go, wait a second, that's a simple and the cheek is a simple. We're going to add them together. Well, maybe, maybe not. The next rule for adding them together is that they have to be from anatomical sites that are grouped together into the same code descriptor. What? What does that mean? What that means is that we can add together scalp, neck, axilla, genitalia, trunk, and extremities. We can add together face, eyes, ears, nose, lips, and mucous membrane. But you cannot mix those 2 groupings. So this one that's on the cheek and this one that's on the chest fall into different code groups. So you cannot add that cheek and that chest together, even though they're both simple. Okay, same patient has another one on the chest that's also simple. So we have the same complexity and the same body part grouping. Those can be added together. So I'm going to code that as a 2 centimeters on the chest. So in order to decide if you can add them together, you have to analyze it like this. And this is the part that I always forget in between times I code this. But guess what? The rules are right here. It tells me. So I don't have to memorize it. I just have to know to refresh my memory of how it works every time I go to read this. I can't just jump to this. So if I tell you that that patient had those 4 lesions, 2 on the cheek, 2 on the chest, you've got to know that that's not going to be 3 that's going to be 3 codes, not 4. Even though there were 4 groups of stitches, 2 of them can be added together. So you've got to analyze these like that, or you're not going to get your codes correct. Okay, the next group of codes I want to talk about are destructions. And your destructions are found in your code book here at 16036, and it's the very next section down. So flip to 16036, and then it's right underneath it is where it starts. Destruction can be on either benign, pre-malignant, or malignant, and it can be with any method of destruction. And so, what are those methods? Electrosurgery, cryosurgery, laser surgery, or chemical treatment. So, cryo is cold. Electric and laser are hot. So we can freeze it. We can heat it and zap it off. Chemical treatment is like a topical, like maybe a wart remover, is a chemical acid that's put on the skin to remove it. Okay, that's your chemical treatment. And then it gives you examples. It could be a condylomata, papillomata, molluscum contagiosum, hepatic lesion, warts, which are just regular plain old warts, malia, or other benign pre-malignant like actinic keratosis, etc. So it could be any kind of lesion. If we are destroying it from any method, these are our codes. So what is the difference between a destruction and a removal? Because we talked about removing lesions already. How does this section differ? Okay, there's a big difference. When we remove a lesion, we have a piece of tissue in our hand. The doctor can put that piece of tissue in a sample bag, send it to the lab to be analyzed for cancer or not cancer. We have something to test. With the destruction, we have nothing. We have zapped it out of existence. We blew up the Death Star. It is gone. Okay, there is nothing to test. That's the difference between these two. Okay, so with your destructions, the doctor would have had to have diagnosed it as a benign lesion or a pre-malignant lesion. Okay. The book uses the only example it gives of a pre-malignant lesion is actinic keratosis. Tests, homework assignments like to use this one to make sure you're paying attention that this code even exists. That your actinic keratosis isn't benign or cancerous, it has a category of its own. So they like to use this one. Okay. Then it is based on quantity. This quantity works just a little bit different than the quantities we've seen before. We have the first lesion, 2nd through 14, and then 15 or more. Okay, so the way this one's going to work is that if you did 15 or more, you're going to code the 17004, and that's it. But if you did under 15, you're going to get paid for each lesion. So if you do just one, you're going to bill the $17,000. But if you did more than one, but still less than 15, notice code 17003 says 2nd through 14 lesions. So I'm going to bill that one because I did a few more. And notice it says each. That means each lesion gets paid for. So the 17000 gets me paid for number 1. How many more do I have? So let's say I did 4. The one code got me paid for the 1. So I have 3 more that I want to be paid for. So I'm going to do that 1 times a quantity of 3. Now I got paid for all 4 that we did. But if you got up to the 15, you're not going to get paid per lesion. They're just going to bulk pay you for the 15 and be done with it. Then we have the benign, works the same way. No, doesn't work the same way. Up to 14, 15 or more. So again, you're not getting paid per lesion. You're getting paid for either up to 14 or more than 15 or more. That's it. One payment for the whole group of them. But now when we get to the malignant lesions, it's separated by body part and it's separated by size. So you're going to code each lesion separately based on size of the destroyed tissue and the location of the destroyed tissue. So some subtle differences between pre-malignant, malignant, and benign, but significant enough that you've got to pay attention to your sections. Okay, Mo is the last section I want to talk about. Mo's. It's 3 sections of codes here. There's only 5 codes, but I split it into 3 different groups. Let's talk about what Mohs micrographic surgery is before we even get into what the codes are actually saying to us. But what it is, and guess what? It explains it up here in the guidelines. But what it is that the surgeon is also the pathologist. And the surgeon is going to have the patient on the operating table, and let's say we're taking off a piece of skin cancer. And let's say this is the suspicious skin cancer on the patient's skin. So when the doctor comes to do the surgery, we're going to take off around it like this, and that's called doing margins. So we want to make sure that we get all the bad cells. We don't want to cut too close to where we still had some bad cells at the margin, which means we didn't get enough. So, in a normal pathology situation, your doctor would take this off the patient. The patient goes home. We send it to pathology. Pathology looks at it under a microscope and says, you didn't get enough. Your margins are too close. Call the patient back. Do some more. So the patient has to be called in for a second surgery another day, and we need to take off more. Well, that's pretty inconvenient to the patient. With Mohs, what the doctor does is the doctor is the pathologist. So we're going to take this lesion off the patient with the margin that I already drew, and the doctor's going to step away from the surgery table, and the patient's still laying there unconscious, under anesthesia, laying there. The nurses, everybody just kind of holds. They're kind of bored at that moment because they're doing nothing. The doctor will then go over to the microscope and look at this and decide, did we get enough? Yes or no? If the answer is no, we're going to come back and do what's called a second stage. And he's going to take some more. He had to scrub back in, by the way. He didn't just walk back over to the table and cut some more. He scrubs back in, goes back to the table, and takes off another piece of tissue margin. Steps away from the table, looks at it under a microscope again, and decides we're good. So this would have been a surgery performed in 2 stages. It means I went back and got more one more time. So I had the original excision and one more extra. So that makes 2 stages. The other thing that I oversimplified was looking at it under a microscope. We actually have to freeze the tissue. They have to slice it into sample blocks, etc. Okay? So it wasn't just slapping it onto a slide and putting it under a microscope. It's very, obviously, much more technical than that. Okay, so when we go to code our Mohs micrographic surgery that our doctor did, they are separated by body part. So we have head, neck, hands, feet, genitalia, or any location involving the muscle, cartilage, bone, tendon, nerves, and vessels. The second group of codes is the trunk, arms, and legs. So your first question is, what body part was this performed on? Pick the right codes. And we've got 2 up here that are together and 2 down here are together. So pick the 2 that are for the body parts we did. Okay? Clean up my screen here a little bit. So I'm going to say that this patient, this was on their arm. So we're going to go with these 2 codes because it was the arm. I have 2 codes. First stage, additional stage after the first stage. Because we could have come back and done a 3rd stage of excision if we needed to. So we don't have a code for first, second, third, however many. We just have first stage, any additional stage. And notice when we code it, we're getting paid for 5 tissue blocks in each one. So the surgery I described was 2 stages. We need a 17-3-13 and we need a 17-3-14. That pays us for the first stage and the second stage that our doctor did because he removed 2 different margins from this patient after looking at it under the microscope. He had to come back and get some more. The doctor would also have to document how many blocks were used. So when they looked at it under the microscope and they froze it and they sliced it, how many did they end up having to look at? How big was this sample? It's a small sample like I drew on the screen. You probably don't need 5 blocks, but let's say this is a larger sample. Let's say I've got a large piece of skin cancer growing on my back, and it's big. Guess what? He's got to look at a lot. Okay? He's going to have way more than 5 blocks. So when doctor documents this, he's going to have to document that the first stage, he had 8 blocks. The second stage, he had 6 blocks. So when I build the 17,313 and the 17,314, doctor got paid for 5 blocks from each stage. So how many have I not been paid for? So the first stage was 8. I got paid for 5, so I'm still owed for 3. The second stage was 6. I got paid for 5. I'm still owed for 1. Add them together. I still have 4 blocks total that I have not been paid for. This code here is for each additional block after the first 5, any stage. I'm going to code 17,315 times all 4 of those blocks I haven't been paid for yet. So now I got my doc paid for every block from every stage that they're entitled to pay. So I'm going to need all 3 of those codes, including the quantity of 4. Hope this makes sense. Maybe watching it twice if it doesn't. Okay, that is the end of what I felt I needed to really cover with you thoroughly on the integumentary system. The rest of the procedures we do on the integumentary are pretty straightforward, but excisions, destructions, repairs are kind of tricky, and so is the Mohs. When you are coding, of course, we start in our alphabetical index, and you're going to look up exactly those words: repair, excision, removal, destruction, Mohs. So if we're doing a repair, which is stitches, people always forget to use the word repair. They just think of stitches and they can't figure out where it's at. If you look up repair in your alphabetical section, always remember, while my stitches might be on my cheek, it's my skin. So it's repair of the skin. Don't go to repair of the cheek, because then you're thinking it's the interior muscular structure. So let's say I have a problem with this muscle that moves my mouth. That would be a repair of a muscle from my face, but that's not stitches. Okay? So it's repair skin, and then you'll see simple, intermediate, complex. Now, when I code it myself, I don't worry about the level at that point. I know that if I go to the simple codes, that the definition of simple, intermediate, complex are right above that. And so I always go to the simple ones and then reread the definition of simple, intermediate, complex and pick which one is the correct one. So don't forget to read your guidelines to help you pick the correct code.